This live webinar, being streamed from Nepal, is with Professor Ajit Rayamajhi talking about Japanese encephalitis.
Hello, I'm Professor Ajit Rayamajhi. I treat patients of Japanese encephalitis. And as you know, Japanese encephalitis is caused by Japanese encephalitis virus, which is most prevalent in Asia, Asian subcontinent, especially rural area, where there is lots of mosquitoes and where there is paddy cultivation or rice eating population where they grow rice. And this Japanese encephalitis virus actually has got an endotic cycle, and it is transmitted by Culex mosquito between pigs and humans are accidental hosts. Japanese encephalitis in humans, in majority of patients, like say 99%, it passes on asymptomatically, or there might be a minor flu-like syndrome like running nose, coryza, mild body aches, etc. However, in less than 1% of the cases, it can cause fever, headache, vomiting, altered sensorium, and seizures, and which is also called meningoencephalitis as a diagnosis. We in children with meningoencephalitis, around 40 to 50,000 patients occur annually globally, causing around 15 to 20,000 deaths. The outcome of Japanese encephalitis is very bad. Around 30% of the patients, symptomatic patients, die, and amongst those who have survived, 50% have severe neuropsychiatric sequelae. How this disease spread in Asia is it started in China in 1945 and has slowly been reported in South Korea in 1948, and then gone on to northern Vietnam in the early 50s and northern Thailand. And then subsequently, we've seen Japanese encephalitis in Burma and Bangladesh in the early 70s. And just prior to that, it was seen in southern India in 1955, and then followed by Burma and Bangladesh. And the disease, the virus was first, the disease was first reported in Nepal in 1978. When there was an outbreak in nearby state of Indian state of Uttar Pradesh. It occurred in Rupandehi of mid-southern Nepal. The virus is known to originate in Southeast Asia, somewhere in Malaysia, and it is on that side. It's been reported in Indonesia in the 60s and Malaysia during that time, and that slowly gone on to be reported later in Philippines and then to Saipan in the early 90s, and then has reached Australia. The Torres Strait reported case in 95 and mainland Australia in 98. The disease burden is severe in Nepal. After being reported in 1978, there has been a syndromic surveillance from 78 to 2003, whereas 26,000 cases of suspected Japanese encephalitis, leading to around 5,000 deaths. Subsequently, from 2004, it has been under the lab-based surveillance supported by the WHO, IPT, Since 2014, surveillance of around 2,400 cases of acute encephalitis syndrome, out of which around 400 cases have become diagnosed case of Japanese encephalitis in Nepal. So the disease burden is very high. The illness causes, basically the illness is a virus which, after infecting the humans, goes and multiplies in the skin tissues, subcutaneous tissue and the lymph nodes, and then slowly progresses by hematogenous route to the brain, and it causes diffuse brain parenchymal inflammation, hemorrhage, and slowly necrosis. It occurs in the brain through passive transfer through the endothelial cells, and and leads to encephalitis. The major area in the brain which is affected is the hypothalamus, the midbrain, pons, medulla, and that is why the typical and also the cerebellum. And so the patients typically have seizures and then cerebellar signs like tremors, and then difficult walking, difficult gait. It also causes multiple seizures, status epilepticus, or fine motor seizures, subtle seizures, and those children who have raised intracranial pressures and difficult seizures to control have a bad outcome, either die or have a residual neurological sequelae. They have a typical mask-like face and fine tremors, which is characteristic of Japanese encephalitis. The signs and symptoms is that the child may present with fever, headache, altered sensorium, seizures, and there might be abnormal movements like choreoathetoid movements, tremors, subtle tremors, increased rigidity, increased tone of the body, and there will be signs of upper motor neuron type of lesions. Also, there may be facial palsy, cranial nerve palsy, especially the facial nerve, upper motor neuron lesion type facial nerve palsy, and the diagnosis is by looking at the serology. That is, the patient will have peripheral pleocytosis. They may have increased neutrophils in the beginning. They may have low sugar, hypoglycemia because of prolonged altered sensorium. In the CSF, the cerebral spinal fluid, the fluid in the back, it would be diagnostic. The cerebral spinal fluid will show CSF pleocytosis of more than between 10 to 100 cells, lymphocyte predominance, and then the CSF sugar would be, the protein would be elevated to between 50 to 150, and then the CSF serum sugar ratio would be normal. And the serology, that is the diagnostic test, definite diagnosis would be to looking at CSF anti-J IgM by ELISA. It generally turns positive after 5 to 6 days of illness in the CSF, or a pair serum samples, which means elevation of anti-J IgM by ELISA in the blood, generally would increase by 10th day of illness. And if it is more than 40 units, it would be diagnostic of Japanese encephalitis. And the other test which are done is hemagglutinin inhibition test, which needs paired samples, so it's not very popular. And the other test is reverse transcriptase polymer chain reaction. After diagnosis, the patient is given symptomatic treatment in the form of IV fluids, because the child may have focal neurological deficit. He may not be able to eat. He might have altered sensorium, not be able to eat himself, take care of himself. So supportive management of fluid, keep him warm, decrease raised intracranial pressure, control seizure, start antibiotic, because meningitis is another differential diagnosis that we think of. And so we start antibiotic, and until you are definitely sure. If not, if you're sure that it is Japanese encephalitis by the result, then you don't need to give antibiotics. And then you need to control seizure, maintain decreased temperature, manage raised intracranial pressure by mannitol, furosemide, and then you also you need to look at bowel bladder habits. Put him on a catheter. If he's not able to feed slowly, you can start on nasogastric tube feeding. The differential diagnosis that we can think of is amongst viral infection. It could be Japanese encephalitis, it could be herpes zoster encephalitis, it could be herpes simplex encephalitis, it could be West Nile encephalitis, it could be dengue encephalitis, or the non-viral would be bacterial meningitis, especially pneumococcal meningitis, H-influenzae meningitis, or meningococcal meningitis. Or it could be cerebral, in our setup, it could be cerebral malaria, typhoid encephalopathy amongst the infective cause, or it could be tubercular meningitis. Amongst the non-infective cause, it could be either metabolic like hypoglycemia, it could be shock, it could be poisoning, it could be diabetes, ketoacidosis leading to altered sensory. It could be diarrhea, gastroenteritis, dyslipidemia like hypo or hypernatremia leading to altered sensorium and seizure. Since the sequelae is important in Japanese encephalitis, lots of people have neuropsychiatric sequelae, and the thing to worry about is these people will have behavioral abnormalities. They will have expressive motor speech difficulty, receptive speech difficulty. They will have uncontrolled seizures like Safal has, and they could also have bowel bladder incontinence. They could have cognition difficulties, learning difficulties. They generally be very aggressive, angry, and they may also have abnormal tones, abnormal movements that they need to really be followed up by physiotherapist, occupational therapist, psychologist. In fact, they need a holistic approach, like a politician, teachers, school teachers needs to be aware of this. The other thing that's been happening on encephalitis is that we've been, since there is no definitive treatment, we are looking into treatment options. So what we've done is, what has been seen is they've done randomized control trial with dexamethasone in Thailand, and they found it hasn't worked. They've done alpha interferon testing in Vietnam, and they found that it hasn't worked. They've also looked at ribavirin for the treatment of Japanese encephalitis in India, and they still haven't been, it has not been very conclusive. What we've done in Nepal is we've done intravenous immunoglobulin trial. Myself was involved in that, leading that, and what we found is we just did a pilot study, and we found there was evidence of efficacy of IVIG in Japanese encephalitis. We found that definitely the neutralizing antibodies to Japanese encephalitis was raised by many folds in those JE positive who received intravenous immunoglobulin as compared to those who were given saline placebo drugs. So it has got a promising end, though there is still no definitive treatment. So all we have to depend is supportive management and rehabilitation. The post-vax encephalitis expectation by the parents is that they have to first say that they secure that the other child that they have should be vaccinated with Japanese encephalitis, and also that the other children in the vicinity. Number two, they have to make sure that no potholes are around. They have to cover their body, the patients and all the relatives, and make sure when they travel outside in dawn and dusk, they need to take precautions against mosquitoes. Use mosquitocidal creams, sleep under bed nets, use mosquito nets, get rid of puddles, and then you can also use pesticides to get rid of mosquitoes surrounding. The The other thing is the Japanese encephalitis virus vaccine. The human part, the vaccine has been quite effective in Nepal. It is SA14-14-2 vaccine that is used in Nepal, and they have to make sure that the child gets immunized with Japanese encephalitis vaccine. And so these are the measures that the person needs to take. And the parents should take. The other thing that the parents needs to be aware of is that he needs a long-term rehabilitation process. They have to be patient. They will have lots of already economic burden by the time the child has improved and is being taken care of at home. The disease illness, the outcome is generally reported as the outcome at hospital discharge, but the disease process itself goes on till 3 months. So the outcome at a hospital, say lots of patients that I've seen have been treated with discharge with sequelae from the hospital and reported as survived with sequelae, has gone on to die at home, or the sequelae seem to have progressed, has gone on to become more severe and has been more expensive. What they have to take care of is also that the economic side of patient with Japanese encephalitis. We've seen in Nepal the cost of acute encephalitis syndrome in children who have severe illness or severe sequelae was coming to around $1,100 per admission. That includes acute admission, transportation cost, loss of job, loss of hour of job, and also transport to and fro to the hospital, and which was around 10 times the monthly income of the annual income of the household. And those with mild sequelae, the duration, the expenditure was coming to around 4.5 times the annual income of the household, which was coming to around $500. So it is definitely an expensive affair that we all need to be very, very careful about. And that is something the parents and the relatives in Nepal are coping up in patients with Japanese encephalitis. Safal, can I ask you one question? How did this illness start? How did this illness start when you were at home? Safal is a patient, my patient. He's a 13-year-old boy from Kathmandu, and he had encephalitis 3 years ago, and he's being treated by our center in Kathmandu. Safal, how did this illness start? Safal is not able to communicate well in English, so he'll be answering most of them in Nepali, and then I will translate you in English. Safal, यो सुरु कसरी भयो? So we have 15 minutes to communicate. Okay, Safal? Okay, so he says he has fever, headache. Okay, so Safal is accompanied by his mom. His mom is with us. Namaste, camera. So she will just say namaste. Yes. So she will just say, yeah, you can just say, yeah, come front. Namaste. Awesome. So Safal will be helped by his mom. He's quite introvert. He's not able to express himself. So Safal says he has headache, fever, vomiting. So his mother will add. This was key word. US word.
On US word, this was the ICU by
Okay, so she says he had fever, vomiting, and altered sensorium. He was unconscious for at home, and so this was in Nepalganj, a nearby city of Kathmandu, and so he was brought to the hospital after 3 days. Then there they had done LP, lumbar puncture, and made a diagnosis of encephalitis, and was flown to Kathmandu. And this was during monsoon, post-monsoon. There was in summer in 3 years ago, and he was referred to Kanti Hospital. And Kanti Hospital ma aara ke garyo? Safalलाई Kanti Hospital ma ke भयो त?
Kanti Hospital ma seizure आइरहेको थियो. एडमिट गर्यो, seizure आइरहेको थियो.
तपाईं अलिकति यता आउनु, क्यामेराले बस्नु होला जस्तो छ. Safal अलिकति यता हो. Okay, I think you should come. Safal. So, yes. So is in yes, mom is also here, so we'll just adjust to him. So, okay. So, yes. And so he was brought to Kanti Hospital. He was altered sensorium, had repeated seizure. And त्यसपछि कहाँ लिएर गयो त?
त्यसपछि seizure रोक्यो ICU मा, वार्डमा लिएर गयो.
And so he was transferred to ICU, and he continued to have seizure in ICU. Okay. त्यसपछि
चाहिँ seizure फेरि रोक्यो थियो हैन, फेरि भयो.
Then he still had seizure. It was controlled, and then there was repeated seizure. कति दिन ICU मा बस्यो? How many days in ICU? So he was kept in ICU for 22 days. That was because of uncontrolled seizure. And त्यसपछि after that ward मा लिएर आयो. Okay. And त्यसपछि
वार्डमा चाहिँ ज्वरो निको भएर सन्चो भइसक्यो थियो, फेरि सिजर आयो.
Okay. And त्यसपछि कति दिनमा डिस्चार्ज गर्यो?
त्यसपछि
2 महिना.
हजुर.
Okay.
डिस्चार्ज गरेपछि घर बसी सिजर आयो.
अनि डायग्नोसिस के भन्यो?
Encephalitis.
So he was kept then after 22 was transferred to the ward, and then there was difficulty in controlling seizure. He was kept in hospital for 2 months and was discharged after 2 months with a diagnosis of meningoencephalitis. त्यसपछि घरमा गएर के भयो? What happened after going home?
बस्न सक्थिन हैन, हिँड्न सक्थिन त्यतिखेर. Okay. हामी फिजियोथेरापी आफ्नो गरेको थियो हैन. अनि त्यसपछि बस्न सक्यो. टोयलेटहरु गर्न पनि सक्थिन. आस्ते आस्ते उसलाई राम्रो हुँदै आयो.
Okay, so he was not able to walk. You had to support him to walk, to go to the toilet. You had to feed him, and then he was not able to talk. Okay, and then when did he go to school? School कहिले गयो? 6 महिनापछि. Okay, so school गएपछि school he went after 6 months. So at home, what was his behavior? What problem did you have? At home, घरमा के problem थियो? घरमै चाहिँ. He used to get angry with sisters. So he has younger sister. Okay. So he has younger sister. He used to get angry. He was very anxious with his sister. And after going to school, what was the problem? Okay. So until 2 years, he was having subtle seizures, occasional seizures, but he is under anti-epileptic drug. हैन, औषधि खाइरहेको थियो. Okay. त्यसपछि उलाई अहिले बढ्न थालेको अहिले आएको समस्या के हो?
अहिले आएको समस्या त्यही सिजर आउने हैन, चल्ने, अहिले काट्ने, अहिले लड्ने, अहिले नसुन्ने. त्यो नभएको चाहिँ राम्रै छ.
Okay, so now his difficulty is he's having so while the anti-epileptic drug was being it was under control and was being tapered, then again he's still having seizure. So his seizure is symptom free sometimes 7 days to 10 days, and then he has occasional seizures, 1, 2, 3 times in a day, and then again he has asymptomatic days. His normal activity without seizure is normal. Normal is normal. So without seizure, uska activity normal is normal, and but what is the problem? What is usko gharma usko साथीहरुसँग स्कुलमा के प्रब्लम छ? What problem?
प्रब्लम छैन तर त्यो सिजर आउनु बेला अरु के पनि थाहा पाउन कहिले लड्छ कहिले पनि यसो हुन्छ हैन त्यही नै हो.
So he is quite anxious and he is also embarrassed.
साथीहरुलाई पनि धेरैलाई थाहा छ टिचरहरुलाई पनि थाहा भइसक्यो.
Okay, his friends know and his teachers know, so he's quite anxious. Okay, so sometimes the seizure occurs. Okay, seizure is less than 1 minute, but just transient, but occurs, and he's embarrassed and anxious with his friends and teachers. Okay. What have you done? So what have you done for this? You are taking anti-epileptic drugs or physiotherapy? Physiotherapy गरिराछ? अहिले छैन. Okay, first physiotherapy was done at home initially, but now he doesn't require physiotherapy. Speech therapy? Speech therapy, you went first to a therapist and then you are doing at home. Okay, for seizure, you are taking anti-epileptic drug, but it is still problem. It is what you're normal. Okay, so the other is the parents are anxious that the seizure may remain lifelong and it may not, although it is not big a problem, but still the seizure is there and there might be social stigma. The parents are quite worried. Ani you sabai गर्नलाई खर्च कति भयो तपाईको? What was the cost of the treatment? Is it okay? So it's around $1,500, $15,000. Okay. So how did you get the money? Is it त्यो कम पैसा हो कि धेरै पैसा हो? 1.5 लाख हुने हाम्रो लागि. Very very expensive. So where did you get the money? पैसा कसरी लिएर आउनु भएको?
जग्गाहरु.
Okay. Oh, you sold. Okay, you sold land for the treatment of your son. Okay, and इसको अहिले यो हात काम्ने ओर्ने कमजोरी त छैन. Only during seizure problem आइराछ. Okay. अनि त्यसपछि अब तपाईले यसको लागि इन्डिया पनि जानुभयो, अरु डाक्टर पनि गयो. You went to India just recently, 2 months, 3 months back. 3 months, 3 महिना अगाडि हैन? 3 months back. It was very expensive. कति खर्च पर्यो त्यसमा? कति खर्च भयो?
25,000.
Okay. Around 50,000 Nepali rupees. That is around $5,000. $5,000 to $10,000. Okay. So are you happy with the treatment in India also? The opinion in India? The medicine was the same, or the medicine was the same? Okay, they did not change any medicine, but we did investigations. They did further investigation, and they said it was most likely encephalitis. Okay, and then you are continuing with treatment. Okay. Yes, back. What do you reflect? तपाईको विचार चाहिँ के छ? यो बारेमा के छ? अनि सफल तिमीलाई कस्तो लाग्छ यो रोगको बारेमा? तिमीलाई के लाग्छ? कहिले ठीक हुँदैन भने जस्तो लाग्छ कि ठिकै छ भने जस्तो लाग्छ कि कस्तो लाग्छ तिमीलाई आफैलाई? What do you think? Do you think this is never cured? Are you irritated or are you adjusted or? कस्तो लाग्छ तिमीलाई? You feel that it's not, the seizure is not going to leave you at all. Okay, so mother is also worried that the child may not be, he might progress into depression or otherwise, as compared to before, he has done much better. But you want the seizure to subside, right? Okay, so seizure control. Okay. So he says he cannot play like other children. Okay. So
मलाई त्यतिखेरै सन्चो भएन भने त्यस्तो सिजर आएन नि त
Okay, so he says there is difficulty in playing games with friends. He's frightened to participate in sports days, in sports, because if he has seizure, it would be embarrassed as well as quite irritating for him. Yes. अरु सबल अरु भन्न तिम्रो आफ्नो विचारमा तिमीलाई कस्तो लाग्छ? पहिलाको दाजुमा राम्रो छ कि राम्रो छैन कि ठीक छ तर यो पनि ठीक हुनु पर्यो कि ठिकै भएको छैन के छ?
पहिलाको राम्रो
लाग्छ. Do you feel it is much better?
सबै कुरा राम्रो छ हैन. Seizure आउँदाखेरि अब
Okay. So seizure has been an issue for him. So he says if he has seizure, then there is difficulty with him. He feels he should be completely seizure free. He wants to be seizure free. Otherwise, he has definitely improved the way the disease has improved. He has definitely improved from the time of discharge till today. But then he thinks, he feels that he might not, he might occasionally have seizure. Just if it is there, it is there. Though he says it has really improved, the life has really improved. But seizure has been his basic issue so far.
2 वर्ष अगाडि सुत्दा मात्रै आउँथ्यो नि. अहिले जतिखेर नि आएको भएर उसले पनि टेन्सन लिन्छ हैन. हामीलाई पनि टेन्सन नै छ कि खै छड्दैन मिल्दैन. कहिले पसन्द जानु खोज्छ हैन. अनि हामी डराएर पछि जान्छौँ त्यस्तो हुन्छ. पहिला सुत्दा मात्रै हुन्छ 2 वर्ष अगाडि. टाउको उठाउने अनि काप्ने हुन्थ्यो अब.
The worry is most of the time in the early days the seizures were mostly during noticed during night. Okay, so now he says once the seizure was mostly controlled and they were tapering the drug, the seizures occasionally present while shopping or going to school, and that has been an issue. So the parents' issue is the right amount of the drug, balancing the drug. Safal has been on 2 anti-epileptic drugs, sodium valproate and carbamazepine, and it's been a challenge looking at the blood drug levels and the doses. So since the seizure was controlled, the drug is being slowly tapered, and the issue right now is that while tapering, there has been again emergence of seizure. So seizure has been an issue, and that is an issue. That is a sequelae, recurrent seizure, uncontrolled seizure, status epilepticus are the seizures that is a sequelae of Japanese encephalitis, and is always a concern of the treating physician and the parents.
हातमा सर्र हुन्छ हैन दिमागमा गएर कस्तो कस्तो हुन्छ उनी सुन्दैन बोल्न पनि सक्दैन अब हामी मुख चलाएको मात्रै दबाउँछ नि हाम्रो देख्छ त्यसपछि काट्छ
यो सिजरले उसको साथीहरु दिदी बहिनीहरुलाई अब आफ्नो के असर गरिरहेछ
बहिनीले चाहिँ गरेछ
what issue has this seizure
म अब यताउता गुटाउँछु भने नामु अब दादाले सन्चो होइन भने चिचाएर बोलाउँछ हैन पहिले औषधि हातले बिदाले लडिरहेको हुन्छ ढोगा लागेको हुन्छ म दबाउँछु
So the seizure has been a concern to. So the seizure has been an issue with the sister. She also is frightened with the seizure. She's more concerned with his. With the brother, he's also concerned. He's getting more attention to that. And you seizure, you यसले गर्दाखेरि अब यो थिएन पहिला
घर भन्ने चिन्छ हैन उलाई के हुन लागेको देख्ने भने दौड्दै आउँछ अनि त्यो चप्पल छ मैले खोल्न पर्छ अनि त्यो चाहिँ बिर्सिन्छ के हो अब जति अब अहिले चप्पलले भित्र बस्छ अनि त्यति सबैले लागेको पछि पल्टिन्छ अब मैले के धानेर पल्टिन्छ
यो सिजरले गर्दाखेरि घरमा जस्तै यो थिएन अब अहिले देखा पर्यो घरमा हाम्रो यसको परिवारमा चाहिँ यस्तो मिर्गी रोग छ परिवारलाई बिहा गर्नलाई समस्या हुने त्यस्तो कुराहरु आउँछ त्यस्तो कुराहरु त्यस्तो दिमागमा लागेछ
छोड्ने रोग जौलाई यस्तो रहेछ भनेर भन्छ
Okay, the parents are more concerned. गर्दाखेरि भन्छ
हजुर
साथीहरूले भन्छन्
साथीहरूले छिमेकीहरूले पनि भन्छ
the parents is concerned that their seizure was not there in the family at all, but now they say the child has got seizure. It's like ghost coming on the rumors say it's like ghost coming within his body, and they have all the neighbors say, oh, the child has got this illness, and he's more of looked down by the society, and so that is also an issue with the parents. Any questions are there? Are there questions there? Can you give me the questions? Yes. Okay. Now is the question and answer session, and this is from David from Australia, and what he has asked is, how do you get the vaccine, and does the vaccine, how do you get, does it have any side effects? Yes, we have 15 more minutes for discussion. So how do you get the vaccine? So the vaccine is provided free of cost by the government of Nepal. It's SA-1442 Chinese vaccine. It's live attenuated vaccine, and it is given in the high risk district. The vaccine was the vaccine began as mass immunization campaign in 24 high risk districts in Nepal, and it was slowly increased to 31 districts. The vaccine in 10 districts were given, in 11 districts were given to children 1 to 15 years, and then in 20 districts were administered to people of all age group above 1 year of age. The vaccine is safe, and after, in those total of 31 districts, after, these are all high risk districts which have reported Japanese encephalitis in the past, and after the vaccine, after the mass campaign, the vaccine has been included in the national immunization schedule given at between 12 to 23 months of age, single dose SA-1442 vaccine, and this is in the national immunization program, and this is provided by the government free of cost. The adverse effect of the vaccine is that this is a live attenuated vaccine, so there are reports that the vaccine itself can cause encephalitis, can cause encephalopathy, which is not very common, which is very rare. The local reactions are there at the vaccine site, like there is redness, there is induration redness, and then tenderness, cellulitis, and then the child may have transient viremia. There is killed vaccine which was developed in Japan, which is very popular in Japan, Korea, and the developed countries, and you require 3 doses, 0, 7, and 30 days, and which is relatively safe. But then, looking at wide experience with the vaccine in Nepal, we find that this vaccine is pretty safe and cheap, and has got very less adverse effect. The next question is about. The next question is by Graham from UK. What he's asking is, what is the best way to reduce incidence in Nepal? Okay, that's a very good question. Nepal has taken a strategy of reducing a case of Japanese encephalitis by mass immunization and surveillance. So they've got this immunization campaign in high-risk districts, and they are thinking of increasing Nepal has got 75 districts. So far, it's been introduced in the immunization campaign in 33 districts. Now they are planning to introduce 31 districts. Now they are planning to introduce in all 75 districts. They have been supported by PATH, by Gavi, and the Child Health, the Ministry of Health is working towards immunizing all children in Nepal, because there have been reports of Japanese encephalitis from almost 68 districts out of 75 districts in Nepal. And the other is active disease surveillance. The surveillance has been by three ways. One is HMIS, which is Ministry of Health hospital, like public health, sub-health post, primary health center, district hospitals, and regional hospital, central hospital, reporting to the Director General Health Office and the Ministry of Health. The other is through the WHO active surveillance program, which means you are actively reporting the case, which is lab-based surveillance. So all cases of all children, all patients of acute encephalitis syndrome, patients of fever with seizure or fever with altered sensorium, or patients with fever, seizure, and altered sensorium within 2 weeks of duration are done serum and CSF testing, paid serum and CSF testing, and these are tested by anti-J ELISA in the two reference lab, which is the National Public Health Lab in Teku and BP Korea Institute of Health Science, and it's a case-based, lab-based surveillance, which is supported by WHO IPD and has been integrated with the acute flaccid paralysis surveillance with measles and neonatal tetanus. And this is the key factor that we are doing. So we're also surveying Japanese encephalitis and introducing the vaccine as mass immunization campaign in the districts where the lab-based surveillance reports have turned out to be positive. Also, we're improving the case management in the sense, like myself, in working at improving outcome of Japanese encephalitis, we've done. I've done intravenous immunoglobulin trial to look at safety, efficacy, and markers of efficacy, immunological markers of efficacy. And so, doing drug trials, I've also looked at fluids, not restricting fluids. We found that children who have been restricted fluids, 2/3 suspecting cerebral edema being a problem, have gone on to be dehydrated, and the outcome has been very bad, adverse in those children. So the maintaining fluids, giving full maintenance fluids in those children, the type of fluids would be a very useful way, and also improving hospital care. We found in our study that all children who were brought late to the hospital were also doing bad in the retrospective data of Japanese encephalitis children in the hospital. So if there is no definitive treatment and supportive management is the only way of improving outcome, we thought that those who were coming late because they were having focal neurological deficit or having altered sensorium, we thought that these children were not able to eat or feed or were not able to drink, and so were dehydrated. So we think improving hydration in these children would improve outcome. So case-based study on improving outcome of JE encephalitis is another measure of decreasing incidence of improving the outcome of the children who already have the disease. The other is again vector control. So the virus lives in an endotic cycle. So vaccinating pig in 2001, the government of Nepal vaccinated 2 lakh pigs, 200,000 pigs. Japanese encephalitis vaccine, and then that had also had an outcome in decreasing the incidence of Japanese encephalitis. Also, vector control, keeping house, decreasing, wet and dry rice cultivating season. Like this year you sow rice, next year some other vegetation, and so making alternate dry and wet paddy field, so decreasing the breeding of mosquitoes, Culex mosquitoes, and also decreasing puddles, getting rid of puddles around the home, using larvicidal medicines may decrease incidence. Also using DDT, malathion, or insecticidals to get rid of mosquitoes in those cases, around the cases where JE is reported. Also, covering the bodies by using trousers while kids are while playing outdoors in dusk and dawn, where the Culex mosquito bites most often, and also using mosquito repellents, cream, and sleeping in under mosquito nets, using nets, using mosquitocidal impregnated nets, mosquito nets. That also decreases mosquitoes getting in and biting. And also, massive increase in the Japanese encephalitis vaccine. So travelers, nascent travelers to the endemic region should be vaccinated against Japanese encephalitis. At least if you're thinking of staying more than a month, should get Japanese encephalitis vaccine. And that definitely would decrease incidence of Japanese, even travelers, migrant workers, the incidence of Japanese encephalitis. Also, they've used larvicidal, Culex mosquito larvicidal fishes, and also some neem cakes. It's like a type of soap that you put in the water, and that actually kills mosquito eggs, and it's larvicidal. So these are things that would have really helped. The third question is, in your experience, what proportion of JE survivors go to make it a full recovery? This is from Alan. Alan, thank you for a very good question. My experience is that, as I said, my experience as a clinician, as a treating pediatrician, as an expert in Japanese encephalitis and acute encephalitis and viral encephalitis, is that the hospital reports that they have saying a patient who has recovered, recovered with a sequelae at discharge is not the outcome. The children needs to be followed up in the community after 3 months and seeing actual outcome, because the disease process actually goes on for 3 months. Those who have been discharged normal have said on to have a complete recovery, has gone on, to have a mild learning disability, mild speech disability, cognition. These are all subtle learning disabilities, behavioral abnormalities that is there, and these children have been gone on to said to have complete recovery. So, though we've found that amongst those children with Japanese encephalitis, there is 30% death and 30%. The 70% have survived, and out of which 35% of them, 50% of them, which is 35% of the total, have gone on to have complete recovery. I still feel, although all those affected, 35% have full recovery, I still think amongst them, half of them would still have subtle behavioral abnormalities, learning abnormalities, neuropsychiatric problems, subtle problems like subtle seizure, which would complicate his life and would make it difficult for his parents. Would again be attention-seeking problems to the family, and so around. 35%, I think around 35% of them have complete full recovery. But then what we need to do is we need to really look at the outcome after 3 months to actually say what his final outcome is. And generally what we do is we categorize the patient into good and bad outcome. Good outcome would be complete neurological and functional and social, lingual, behavioral recovery. And the bad outcome would be residual neurological sequelae or death. And you can see the outcome has been affected by how quick the child has been transferred to, the hospital, how quick the fluid has been administered and supportive management has been installed. What is the viremia of the virus infected? What is the immunological baseline immunological status of the child? And also when we look, we also look at the we found that the seizures, the type of seizure, the duration of seizure, the duration of taking control of seizure, and also raised intracranial pressure. So if the child has got raised intracranial pressure and has got a recurrent seizure, and these have led to bad outcome. And so these are things that we need to take care of whenever we're treating the child with Japanese encephalitis. First of all, I'd like to thank the Encephalitis Society for arranging this live webinar, and this has really given us opportunity to talk encephalitis as a clinician, as a patient's experience in a whole. As you know, Japanese encephalitis is a major killer disease of brain infection in Asia, Asia Pacific, Indian subcontinent, and it is still expanding. It is transmitted by mosquitoes, and it is the vectors are the birds. So there is a rapid growth. We know there is a vaccine which is controlled, but it does not have human are not the only limiting host. So so it cannot be eradicated like smallpox or polio, because the disease is transmitted by pigs, wild boars, birds, and we can't immunize them and we can't get rid of the virus vaccine. So it is there to stay. So we need to focus at we need to focus at the management and the treatment and the rehabilitation of the patient as a whole. There are reports the disease is not confined to south of Nepal and south of Nepal and in the lowland of southern Nepal. It has also increased to the hills and the mountain districts. So we found that temperature of 20 degrees Celsius is good for the mosquitoes. So this encephalitis is going to be a major problem not only in Asia. It's going to go to Europe, Americas, and the Africa. So we need to be very cautious about managing children with encephalitis. We know immunization vaccines has control, but then we also need to take into account the treatment and the process of decreasing the neuropsychiatric sequelae.